Hi, I'm Nancy McDaniel, and today we're going to be demonstrating and learning about the cardiovascular exam. I have washed my hands outside the patient room, and I'm going to greet the patient. Hi, I'm Nancy McDaniel. I'm your doctor today.
Hi, I'm Mike. It's nice to meet you.
Nice to meet you. First, I'd like to make sure that you're feeling comfortable and you're well today.
Yeah, very comfortable.
Okay, and what we're going to be doing is I'm going to be looking at your chest, inspecting your chest, and then eventually inspecting your pulses and feeling your pulses. If you're comfortable, can we take the gown off so we can demonstrate some of these techniques? And in physical exam, thank you. In physical exam techniques, we always go through kind of a series of, we do inspection, palpation, sometimes percussion. Percussion is not done very often in the cardiac exam. And then we have auscultation. So we have 4 basic steps that we're going to go through. And so when you have a patient in cardiology clinic, you would inspect their chest, looking to see if you see any unusual either breathing or cardiac motions. He's breathing very comfortably. I don't see any abnormal motions of the chest. And so that's basically it for inspection of the chest, looking for symmetry, ease of breathing, and no unusual motions. Typically for the cardiac exam and for the abdominal exam, you should be on the patient's right side. It makes feeling for the cardiac impulse easier. Listening for certain parts of the cardiac sound is easier on the right, and definitely for the abdominal exam, you would want to be on the patient's right. There are some situations in the hospital or in an oddly set up emergency room or hospital room, you may be on their left. It makes it a little awkward. You can do it, but typically you're on the patient's right. So we're inspecting his chest. While in this position he's sitting comfortably, I'd also, go ahead and look a little bit posterior. Okay, so I'd also look at the back of the chest and in the lateral aspect of the left chest, looking for any scars. So we're looking for asymmetry, any discomfort. I'm looking for chest symmetry, also any scars. If somebody's had cardiac surgery, I might see a scar here. I might see a scar in the left lateral decubitus area, and he has none of those. But that would give me some hints about cardiac history. Also, if the patient had a pacemaker, it would be up here under the left clavicle. So the inspection looks normal. So the next thing we're going to do is I'm going to have him lay back. Always pull out the support for the legs. You'll usually find them. Are you comfortable laying there? For most cardiac examinations, you're going to have somebody recumbent, and usually at about 30 to 45 degrees. This is for several reasons. Usually it's a pretty comfortable position for people. If they're all the way flat, they may not be very comfortable. People can usually breathe comfortably in this position. Frail people or people who are not very certain may need somebody next to them so they don't feel like they're going to fall off the exam table. We're using the gown here as a drape. There's always sheets in an exam room, which you can also drape the person. We'll talk later about examining a female patient or somebody who's not comfortable without the gown on. Generally, gowns opening in the front will help you get an adequate examination. So the next thing we're going to do is we're going to, again, inspect. We're going to, in this roughly 45 degree here, we're going to look at the pulsations on the neck. You can look at both sides of the neck, looking for any dilation of the neck veins, which he has none. And then we're going to look for pulsations in the neck using a tangential light source or a pen light. And this is a surrogate for the central venous pressure. If somebody's vein is dilated and you can see a big vein, like when somebody's lifting weights way up to the angle of the jaw, you might know that either their fluid status is elevated, so they're hypervolemic, or they may have heart failure. In a normal, healthy person, you may not see the jugular vein distended at all, meaning that they have a normal central venous pressure, or if they're dehydrated, you're not going to see it. So I would assume that this is normal here. Generally, you inspect it from the right because that's better seen. Then you can, so we've inspected and we've looked at the jugular venous pulse with using a light source. Then we can palpate the chest. And there are certain things that you typically palpate for. One is to find the point of maximum impulse, and that's where the left ventricle essentially taps the chest wall, and it's palpable in about 3/4 of people. About a quarter of the time you can't find or feel the point of maximal impulse. I can feel it easily here. It's generally at the 5th intercostal space, roughly the mid-clavicular line. If you're having trouble feeling this, you can have your patient roll slightly to their left. Do you mind doing that? So kind of a half left lateral decubitus, which brings the apex of the heart more toward the chest wall. This can sometimes help you find the point of maximal impulse, or PMI, easier in a patient that you can't feel it when they're lying on their back. You can come back to a flat position. So that's the point of maximal impulse. As I said, about 25% of the time you won't be able to feel it. If you feel a very large area, and generally what you're going to feel is about the size of the end of your thumb, is how big the impulse is. If it's much bigger than that, they might have a dilated heart or heart failure. But generally it's about between a nickel and a quarter is about how big the point of maximal impulse is. The other thing you can do is lay your hand on the patient's chest and feel for any big movements of the chest, and these are called lifts or heaves. Most people, you don't have them, but again, heart failure, or if in the case of somebody who might have congenital heart defect, over circulation, you might feel a rocking motion of your hand. If the fingers are coming up, that is generally associated with a left ventricular lift or heave. And if the heel or the lower portion of your hand is coming up, that's a right ventricular heave or lift. You don't feel them very often, but that's part of inspecting the chest and palpating. If you have, depending on the complaints, you know, if somebody is saying that their chest wall hurts, you may feel the sternum or the breastbone, feel the xiphoid process, and you may palpate the ribs if there's complaints there. But that's the basic palpation of the chest wall. The other things that you palpate are the pulses. And you can really kind of do this in any order that you like, but typically you will feel brachial, radial, palpatile, and then the pulses in the feet. In children, you typically will feel femoral pulses as well, and in certain conditions, you're going to want to see the timing of the pulses relative to each other. That's really more of a specialty thing. So I'm just going to demonstrate, and pulses you're always going to do both sides because there may be differences. I'm going to feel the brachial pulse above the elbow, between the shoulder and the elbow, feeling in between the biceps and the triceps, and you can feel the pulse there. And then you can feel the brachial pulse in the anterior cubital fossa. I would then feel the radial pulse. The CPD list also includes the ulnar pulse, which we don't always feel.
Pretty straightforward.
Pretty straightforward. And if you're putting in an art line, always,
Right. Yeah.
always palpate that. And the popliteal pulses is, and if you bend your leg, it's one of the hardest pulses to feel, particularly if somebody has peripheral arterial disease. You use the fingers of both hands and you surround the knee and to feel the popliteal pulse. It's not always easy to feel, and if a person is quite large, it can be difficult. He has easy to feel popliteal pulses. And then you have two major pulses that you feel on the feet. One is the dorsalis pedis. It's generally between the first and the second metatarsal space, usually halfway up the foot. And again, very easy to feel in this patient. It's right under my fingertips. And then the final pulse that you feel, or at least this is the order I go in, is the posterior tibial, which is right behind the ankle on the inner surface. And the key to feeling pulses is don't press too hard because you can obscure the pulse. So you have to press fairly lightly. And so and you would do that on both sides to make sure that the pulses were symmetrical side to side. Generally, after feeling the pulses in somebody's feet, I will re-wash my hands or re-gel them before going to the next steps. And so then the final pulses that you're going to assess are the carotid pulses, and you always do this one side at a time. And so you're going to feel in the neck till you find the carotid pulse. And again, you're not going to put a lot of pressure on this because you could cause somebody to have bradycardia or actually faint if you press too hard on their carotid pulse. But you're going to find that the carotid pulse is on each side, and I hope I didn't make you uncomfortable. So we talked about inspection of the chest, which you do, and then palpation of the chest wall, and with particularly in an adult patient looking at the jugular pulsation. And then the next step that you go to is cardiac auscultation. So and in general, so you have the stethoscope. Most have a diaphragm, which is the larger, flatter surface of the stethoscope, and the smaller cupped portion, which is called the bell. For general cardiac auscultation, the diaphragm is what you're going to use most of the time. This gives you a wide range of sounds that you can hear. The bell is good for lower pitch sounds. So as you're listening to the heart, you use both of them to assess the heart sounds, but the bell is used for low pitch sounds, and typically it would be the gallops are low pitched. They're harder to hear, so you would need to listen there. But for basic auscultation, you really use the diaphragm. So typically when you do auscultation, there's 4 areas where you will auscultate the heart sounds. And the mitral area is essentially where you felt the PMI, mid-clavicular line, roughly the 5th intercostal space. Then directly over that towards the sternum is the tricuspid area, again roughly 4th or 5th intercostal space. The pulmonary area is the 2nd intercostal space, closer to the sternum, in the parasternal area, and then the aortic in the 2nd intercostal space to the right of the sternum. So I would typically listen with the diaphragm at the mitral area, a couple of cardiac cycles. Now I'm listening at the tricuspid area, and the diaphragm is firmly placed on the chest, not hard, but firm, so it's not sliding around. And listen to the pulmonary area, 2nd intercostal space, parasternal area, and then I move it to the aortic area, 2nd intercostal space, roughly, parasternal as well. Then typically what I do is then I turn the stethoscope over, so I'm going to use the bell now. And the bell you apply lightly. You want good contact with the chest, but if you press it down firmly, it becomes a diaphragm. So you obscure those low-pitched sounds again. So I hold it kind of with my 2 fingers and make it pretty steady, but not tight. So I do the listen with the bell in the mitral area, the tricuspid area. And I typically listen to the pulmonary and aortic area with the bell as well. Although you don't pick up many low-pitched sounds here. It's primarily here. That's the basic auscultation. If you have a patient, and this is with aortic valve disease, you would also listen to their neck to listen for what we call a radiation of the heart sounds. And if the aorta is roughly here, this is the aortic area, you might hear abnormal heart sounds in the neck as well. And so the basic cardiac auscultation is listening for the first heart sound, which is the mitral and the tricuspid, and the second heart sounds, which is pulmonary and aortic, and any sounds in between, which are heart murmurs, clicks, or gallops. So those are that would be basic cardiac auscultation in a patient. If you're having trouble hearing heart sounds, again, you may need to have the patient roll into the left lateral decubitus position, again bringing the heart closer to the chest wall. And the only other maneuver you might do is if a patient has aortic insufficiency, you would have them sit up and lean forward to listen to the diastolic murmur. And but typically in most patients you don't need to do that. So that's the basics of a cardiac examination. Now we're going to talk about and demonstrate some of the techniques you can use while examining a female patient. In general, most of the cardiac exam is done exactly the same as with a male patient, but you need to particularly focus on making sure that privacy for all patients is respected and also their modesty. With a female patient, the breast tissue doesn't obscure the cardiac exam, but sometimes, especially when feeling for the point of maximum impulse and auscultation in the mitral area, you need to use some special draping and often ask for the woman's assistance, particularly if they have large breasts, so that you can get an adequate cardiac exam. For the purposes of education and in our CPD, we ask that our female patients wear a sports bra so that we can teach the techniques. In most clinical situations, either in the hospital or in a clinic, to get the best cardiac exam, all the clothing should come off the upper body, the sports bra, regular bra, any kind of undershirt or that sort of thing. Again, we want to respect the modesty and respect privacy, but you do want to get an adequate exam, treating the woman just as you would treat a man. So in respecting a patient's modesty, what I'd like to do is take a look at the front part of your chest. So if you wouldn't mind bringing the gown down, and that's good. And if you could just a little bit farther, and I see that she has no scars and no rashes, and just inspecting the front part of the chest. And thank you, you can put that back up. While you're in this position, I'm going to look at your back as well. And if you could raise the left side of your sports bra for me, just making sure that there's no lateral scars or anything. Very good, thank you. And I would have known that from history, but that's one thing that you need to observe. And now I'm going to have you lay back. So we're going to do the rest of the cardiac exam. And if you would pull the gown up a little bit so we can make things a little easier. So okay, and now I'm going to inspect the lower part of your chest, if you don't mind pulling up very nice. So again, no scars of any sort here in the lower chest or the upper abdomen. Thank you. Okay, you can put that down. Then what we do with the cardiac exam is after we inspect, then I'm going to do what's called palpation. That's using my hand to feel the pulsations from your heart. And so that the thing about doing either the exam for the point of maximum impulse or the if you were doing an electrocardiogram is that the breast tissue needs to be moved out of the way. For most women, they prefer doing this themselves. So while you're covered and draped, if you will just move your left breast kind of up, perfect. And then I'm going to take my hand and feel here at your lower chest. And what I'm feeling for is your heartbeat. Okay, you can feel it in the pulse. I can also feel it in the chest. And just like with the man, you're going to feel how big is that impulse and where is it in the body. And again, it's mid-clavicular line, roughly the mid-clavicular space. So I can feel that and very easily. Then the other thing I'm going to do is, you're in a perfect position here, but this I'm going to slip my thumb right on your breastbone here. And what this allows me to do is to feel for any heaves or lifts, again, just like we demonstrated on the male patient, that if my fingers are being lifted, that would be a left ventricular heave or lift, and if the heel of my hand comes up, that would be right ventricular. And so while protecting her modesty and privacy, we can get this done. And this is also a very good position here to, and if you want, we can use this, use the gown, again, to cover. Some gowns have an opening under the armpit or the axilla, which you can use to listen. But roughly where the PMI is, I'm going to demonstrate listening to the mitral area. So we have really very little skin exposed here, but I know I'm in the right place and get an adequate cardiac exam, so I can listen in the mitral area with the diaphragm, just like we did with the male patient, and listen to several cardiac cycles. Again, I'm going to move closer to your breastbone and listen in the tricuspid area. And really, you don't need much skin exposed. You can actually listen under the gown, but can't have camis and undershirts and those sorts of things because you won't be able to hear well. So I heard mitral, tricuspid with the diaphragm. While she's still helping me, I could at this point modify my exam and listen with the bell. So because the mitral area is still exposed, so I can listen for those low-pitched sounds. I can listen at the tricuspid area for the low-pitched sounds. In the man, I did the 4 areas sequentially, but again, because she's helping me, we can just modify our technique slightly. Thank you, and you can relax. And now, as we did before, we're going to expose just the little part here of the upper part of your chest. And with the sports bra, it's really quite easy. We can easily identify where the second intercostal space is. And we can listen just to the left and the right of the breastbone, to the pulmonary and the aortic area. And that's, really not much different. Again, if you want to, you can put the gown on top, exposing very little while you listen, and then move to the aortic area. So with a little modification, you can do this well. And then there would be really no difference in examining the jugular venous pulsation or feeling of the carotid pulses because it's just the neck area that is exposed. So really it's listening to the heart and palpating the heart that's really any different. When you're examining a female patient. And people's reaction to having a gown on or being examined varies quite widely. Some people are more modest than others, but always be respectful of their wishes and kind of work with them. That concludes a basic cardiovascular examination, including inspection, percussion, and auscultation.